You guys see a black screen or a blank screen?
It's the cover of the book
You guys,
or the PowerPoint.
you do see the cover of the book. That's good. That's good. That's good. Well, no, there it went. I'll tell you what, one of these days, I'm going to figure all this out. When I do, we're going to be golden. All right, let's try this again.
It's back.
Cool. All right. So attendance, I forgot about, but everybody's here. I saw 16 smiley faces, so we're good to go there. And that's about it. Oh, hey, one more thing. A couple of you have reached out and said that you have other alternate plans moving forward on this day where you needed a day off. Again, as long as we're doing this meeting online, there will be no makeup time. I'll just send you a link to this. Actually, I won't even have to because I'm going to keep posting these videos in that little YouTube playlist link. If you have technical difficulties getting to that, let me know. But I do want to be able to give you I want to give you that option to be able to go through and do that. So I'll either send it to you, or there is some alternates. Some of the alternates is you guys being able to sit in with another class that's running concurrently with ours. But again, that is what it is. They're a day or two ahead of us, so you might have to wait and go back. And again, you might just end up listening to a lecture. So you might as well listen to ours. So that is the benefit of doing this online, is that we're going to have the ability to do that and just send you the link, or you can watch it on the old YouTube. So that's really about it. So getting into this. So the only things that I need you guys to know out of this is patient privacy is pretty important. I think we already know that. HIPAA laws, I think we're already familiar with most of those. Just know that those exist and that prevents us from talking about a patient. The big thing that prevents us from doing that we always fail to do, we don't necessarily need patient demographic information to violate HIPAA. If that patient can look at any of the communication that you made regarding that run and say, hey, that's identifiable and that's mine or that's me, that's technically a HIPAA violation. So when I'm showing you 12 leads, if that 12 lead is so significant that a patient can identify that as being his or hers, then technically that is a breach of HIPAA. If it's some weird congenital disease or something that only a few people in this area would have, and we're talking about a specific run that I made that went to Children's Hospital or whatever it is, that would ultimately be a breach of HIPAA. So other than HIPAA, we're going to talk a little bit about, we're going to spend most of our time in this talking about documentation and physically how we write our reports. And that's going to be pretty important for us. You guys, the hardest thing for you right now is going to be breaking the habits that you're currently in. So depending on, if you think about your reports, there's a couple different ways people are writing these. You can write a report based on chronological order. So you're just telling a story. We got dispatched to this, we showed up, they said this, they did this, we did this. And it's kind of a back and forth chronologically through the run. The other option that a lot of people have is some type of formalized template. And we'll talk about a couple of those little templates here in a little bit. But otherwise, really, we're going to talk a lot about what should go into a PCR and what should not go into a PCR. Somebody give me a definition of objective? What is an objective piece of information?
Something you can measure.
Something that's measurable, correct. Subjective is something that's more of an opinion to you. So, you feel like, or your differential diagnosis. So when you're getting down to trying to figure out what it is or what it isn't, some of that is subjective. Now, you say the patient has a fever, that is absolutely measurable. But this person has chest pain consistent with a heart attack. That is more of a subjective statement. That's you have some proof maybe, but according to your training and your knowledge in your experience, this looks like all of the things that I know to be a heart attack. So that's more of a subjective thing. We know that these things need to be complete. They need to be accurate. They need to be 100% done. A lot of our departments have like red boxes on our electronic PCRs to tell us, hey, stupid, you forgot something. But again, that's department specific. We also know that I've been to court for medical runs. I've only been to court twice. And both times the case was handled before we even actually got going. But both of those were over a year from the occurrence. One of them was a domestic violence case, and one of them was a DUI. So if you think about it, a year later, depending on where you work, you've probably had quite a few runs since then. You've probably had quite a few DUIs since then, and you've probably had quite a few domestic assaults or violence. So thinking about that, what's in your report is the only thing you're going to have to go on. When you look back at your report from a year ago, you should be able to basically you should get an idea for a couple things. First and foremost, if you're looking at your report, you should know right away based on the template that it's yours. So you should write it so consistently, the same way, in the same format, in the same manner, that you can look a year ago and say, well, first of all, this is my report. The domestic violence one, that is literally all they needed me to testify to. Was this your report or was this not your report? And if it was, that's I don't even know where they were going with that, but that is literally all they asked me. So kind of keep that in mind. So again, it needs to be complete, accurate, and legible, but it needs to be yours. And again, if I look at any of mine, I can tell from 5 years ago, like, yes, that template, that format, that is my report 100%. So try to start thinking about that. Omissions are just as bad as anything else. We know that the defense attorneys, God forbid, it needs to go to court or some kind of litigation. We know that us forgetting stuff it basically means it didn't happen. And I don't want to go too deep into that because I think we're all pretty much aware of how that goes. Otherwise, as we go through here, pretty much we have to paint this picture. A lot of our reports do a really good job of creating a timeline where, all the times are going to be in there, what happened and when you took vitals, all of that stuff. You're going to start painting this whole chronological picture without the narrative. So, again, that's going to kind of go without saying that it all kind of needs to be together and in order. Billing is not something I don't want to go too deep into because, again, billing is one of them things that we're going to have somebody very specific that's going to deal with that on the department level. We're going to find out shortly that there's some very specific information that has to be mandated by the state of Ohio for billing. Things like demographic information. There's supposed to be a race ethnicity, where they went, what the disposition was, stuff like that. And that all has to do with medical billing and coding. So that's not stuff that I would worry too much about. Just know that a lot of those blocks are mandatory or required for a reason. And it's usually something to do with billing. So some of the types of PCRs, most of us are electronic now. That's been kind of a godsend because you can send it over. You don't have to sit and handwrite a report anymore. So regardless, the electronic ones, there's probably 5 or 6 different big players in that game. But a lot of these, they're all the same. Whether you use our department just switched to the image trend system, which is some version of the top right one. But there's a ton of them, and every department's going to be a little bit different with what they use. Shifting away from paper, we already talked about that. Again, I don't want to belabor this any more than we have to. So here's our documentation, and again, basic template. The biggest one that we're going to get into as far as templates are concerned is going to be the method that you use to physically document that stuff. And if you've got a textbook, there's some pretty good examples of these. Again, the big ones are going to be like the CHART method, CHART. And the other one is they call it a SOAP method, SOAP. And those kind of show up. They show up in it. Again, there's examples in the textbook of those very specifically. So within this documentation, somewhere there has to be a transfer of care, which is basically who you left it with or the patient with. When it comes to that, the big thing for you guys to take home is that it has to be an equal or higher level of care. So you cannot transfer to a PCA. You cannot transfer to the registration person. Just like anything else, you have to transfer care to. In a lot of cases, you have to transfer care to a nurse or to a doctor. Is a lot of the department guidelines and protocols for that. Making a phone call, we usually try to document that. As far as the dispatch center, they have a medical director, and we talked a little bit about this already, but they have to have a medical director that assigns and signs off on protocols for them. So I know most of the counties now are trying to go to a system where for chest pain, they will literally tell them to take their nitro. They'll literally tell them to take aspirin, or they'll tell them to administer their own EpiPen. And a lot of that has to be done under doctor's orders. So there's usually a spot on these reports for us to document any of the care that happens before we physically get there. Another option of that is like the CPR, like who started it and who noticed it. Refusals, we'll talk a little bit more about this in medical, but with the refusals, this is one of the most dangerous legal openings that we would have against us is a refusal. You take a refusal and then the patient dies, or the patient has some turn of events, and you're the last person that had contact with them from the medical standpoint. And they usually try to find something that you may or may not have missed. So documentation for a refusal should be very, very thorough. That's a pretty important thing for us to kind of understand. We'll talk about some of the consent once we get into legal, but implied consent is basically the patient is unable to give you a verbal consent. So we're just going to imply, or we're going to assume that they're going to give us consent. If they're unresponsive, they probably need some kind of help. So we'll act under those auspices. Skip through this talks about a witness for refusals. And again, a lot of this is department policy, and I don't necessarily want to get too deep into this. We know that we're going to document everything. Workplace injuries. This is another category that we need to take into consideration, not necessarily from the legal standpoint, but for the patient standpoint. If the patient falls or the patient has some kind of specific issue, for example, a construction worker that had something fall on them, how you document the PPE that particular employee had may literally grant or allow them to refuse his workers' comp case. So, if he had a helmet on and you document that the patient had a helmet on, that literally could just rubber stamp his claim. So some of the things that we put in there, we need to try to be kind of detailed. And that's really about as deep as we should go with that. Special stuff. That's the narrative. We'll talk about that in a minute. Where'd it go? There's special circumstances. Every one of these reporting systems, they're a little bit different. If you have a bus full of kids and nobody's injured or one person's injured, the department policy would dictate that you should probably either create an incident for each one of the students that were involved, or there's just one blanket incident report for everybody. Something I would suggest with that specifically, especially because they're minors, is if you only have to do one report, I would absolutely write the names of every student that's on that bus in there. And then, of course, the next problem is going to be we have to contact parents, because, again, we can't just release the students to whomever. So that's a long process. But, again, there's going to be a lot of documentation because there's a lot of people involved. All right, so the narrative. This is kind of what I wanted to hit on hard today. The narrative, it needs to be detailed, accurate, and specific. Again, it needs to be yours very specifically. And you basically need to figure out what your department's method is. So it could be this chronological order, which very specifically is just chronological. A good example for when to use this or when this works really well is like a non-breather or code situation, because to try to break it down into categories is going to be kind of difficult, especially early on until you get pretty comfortable with these templates that are out there. But just chronologically, what happened? There is nothing wrong with this. Contrary to popular belief, when you write a report, somebody is going to probably critique it, whether that's a QA officer, whether it's whoever it is within your department that looks at this. But at the end of the day, this report is your report. It's not theirs. So there are department policies that say, hey, you need to include this, and this, or you need to be very specific about whatever it is. But at the end of the day, this is your legal document. For you. So this is not necessarily something that the department should really care a whole lot about as far as templates concerned, just to make sure that it's physically there and complete. And again, more importantly than that is that that it's yours. And again, if you get into this routine early, it's going to really help you long term, because honestly, you'll know what you've forgotten. It'll help you to remember things that you normally would forget, because again, it's built into the template in your brain. That's where chronological order fails. It doesn't necessarily provide you with something to spark your memory to remember, like, hey, I missed this particular part of this report. So this is probably my least favorite of the ones that we're going to talk about today.
Hey, Adam.
Yeah.
For this, I'm just reading through their chronological report.
Yeah.
It lists off a lot of their vitals and stuff. With the computer based, a lot of that stuff is typed in. Like we use ER, and where you put in your pupils, it puts the size, it puts the time when you took that vitals. Is there a need to rewrite that in the narrative if it's not relevant? Like pupils and cardiac are probably not related. Is it necessary to write that in there?
That's a hard question to answer. No, not necessarily, because it does physically exist elsewhere in your report. Now, that said, fast forward 2 or 3 runs and you have a non-breathing heroin patient or an overdose patient, and those pupils now do matter. You're not going to have that baked in template in your brain that you type the same way every single time to try to show that this is something that we're going to be doing. So that's kind of a blessing and a curse to put this stuff in here. Vitals, I don't know that I would necessarily worry too much about them unless they were relevant to your treatment. So if the blood pressure is really low and the pulse is really high, we know now that could be a good indicator of a shock, some type of shock. So why you treated the shock is based on those vitals. And if those vitals aren't necessarily in the same spot that you explain why you treated it, that could be confusing to a reader. So again, it's, if you 100% of the time do not put the vitals in there, then 100% of the time you should be able to know that I need to go back to the vitals section to justify why I did something in my narrative. Conversely, the pupils, again, my report is 100% the same every single time, and it can all be a negative. It can all be basically just pupils were fine, or what, the proper terminology for it. But basically, if it's always in there and it's always the same, when it's not the same and it's not always that particular template, it's there for me to be able to jump off of and not forget. That really comes into play with the pertinent negatives, and we'll talk about that here in a minute. But if a patient has shortness of breath, you can go through this whole diagnosis for shortness of breath, and you can come up with all these reasons why this patient is short of breath. But if that patient is short of breath and has chest pain, that is a very, very different thing than a patient that has shortness of breath and no chest pain. So we know that cardiac events a lot of times manifest with shortness of breath. And again, I don't want to get too deep into that, but knowing that 100% of the time, I always put the negatives that the patient denied, chest pain or shortness of breath or nausea, vomiting, or abdominal pain or recent illness, or if I can put all these negatives in there when there is a positive. There's been times where, I'm typing out the negatives, just the same thing that's in my brain 100% of the time. And it triggers to say, hey, wait, it reminds me that, well, no, he did have nausea. So that allows me to kind of go back and kind of put all that together. But again, it's the same template every time. So I would challenge you guys to go ahead and do all of the physical assessment stuff and to get all of that in here from the beginning. That way it's kind of baked into the brain. But again, the vitals I'm not too particularly worried about. So here's some of the templates. So SOAP, this is not my favorite, but this is better than chronological. So literally you just put all the subjective stuff. So you were called for this thing. The patient says that it feels like this. It's everything that the patient's trying to explain to you. When you get into your assessment, that's more of the objective stuff. That's the stuff that you can physically justify, that you can physically go through. So if you're physically assessing them, all of the objective stuff would be next. So, your basic run-of-the-mill chest pain patient, sorry. You'd call for a 78-year-old with chest pain. Patient says it was, it started when I was mowing the lawn about 30 minutes ago or whatever. I don't have history of this. This has never happened to me before. The pain's a 7 out of 10. And then some of the pertinent negatives there that you see. Patient denies the shortness of breath and nausea, vomiting, and patient denies recent illness or recent travel or whatever it is, no allergies. And you put all of that stuff in there with what they said. Now, this is not chronological. A lot of people, when we read this, we want to try to read it as a chronological thing, and it's not. These are just paragraph, just chunks. So you start doing the objective stuff. So the patient was sitting there. We moved him to a cot. We strapped him down, whatever. We took vitals. Patient, the airway was intact. The breathing was okay. However you decide to write your report, the goal of this is just to make sure that you write it the same. All 16 of you don't have to write it the same. And nobody in this class is going to write it the exact same way as I do. But the important thing is that it's consistent for you so that you can remember this. And so once you get down into like the assessment, this is more like the differentials. So he could have an MI. He could have indigestion. The patient could have, a pulled muscle or something in the chest. It could be all this stuff. And then your treatment plan is the very last part. So what did you do? So I started an IV. I did vitals. I started an IV. I gave them oxygen, gave them aspirin, gave them nitro. We went to whatever hospital. We transferred them to bed number 5. We gave a report to a nurse or whatever. So this is just a very, very simple breakdown of pretty much any run, and you can insert any run here. So an asthma attack. You were called for a 16-year-old male with asthma, history of asthma and shortness of breath. And you could pretty much go through that whole thing. Patient states they took their own albuterol treatment, did not help. They have asthma, they've had asthma, they were running around outside when it all happened. And then for your objective stuff, patient, clearly short of breath, an increased work of breathing, blah, 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 blah. For the assessment, this would be where you would say, this is probably an asthma patient. This is an asthma attack. And then your treatment is as follows. If you guys looked over that beta 2 thing that I sent out yesterday, that's going to start tying into this. So, something for here, the patient needed that. So the patient got albuterol or got a Duaneb and got, whatever you gave the patient, gave an IV and fluid and, all the other stuff that relates to asthma. So that's kind of one of the layouts there. Any questions on the SOAP method? No? Okay. Whoops. So chart, this is what I physically use. This is my personal favorite because it's just detailed enough that it gives me that whole objective and the subjective side of things can be kind of confusing because a lot of that does somewhat blend together. If the patient tells me they're having trouble breathing and I can see that they're having trouble breathing, technically that falls under both categories. So for me, that got kind of confusing early. So this is how I did it instead. So usually I'll write a report today and I'll post it just so you guys can kind of see what mine looks like. But this is pretty much how it is. And I don't necessarily write the CHART in the margin. I usually just separate them by paragraphs. So I'll put, dispatch for a 78-year-old male complaining of chest pain. Upon arrival, patient said it was this, it feels like this, it's this crushing chest pain. It's an 8 out of 10. Patient has previous history of MI. So C and H are kind of going to go together on my report. And I just kind of roll right into, so that, the chief complaint is what the patient says. So you can't change that. The patient says, I stepped on a nail and it hurt like hell. I write down, it stepped on a nail, hurt like hell. So, the chief complaint, the 78-year-old male is complaining of chest pain, said it's the worst pain he's ever had. Patient has cardiac history, had an MI 2 years ago. He was in the cath lab. Whatever I know about the history there, I'll put. And then for the assessment, my assessment is the exact same 100% of the time. So to go back to that previous question, every one of my reports, when it gets to the assessment part, I start every single one of them with the patient was alert and oriented, had a GCS of 15. And then I go through the ABCs because ABCs are going to be, we're going to know that that's the top priority for us. So the patient's airway, it's patent and being managed by the patient. So it's patent and self-managed. That tells me that it's an open airway and that they're breathing on their own. So alert and oriented, GCS of 15, airway is patent and self-managed. I go to breathing, lung sounds equal in all fields, bilaterally, however you write that. And then skin is pink, warm, and dry. So I literally went through A, B, and C and level of consciousness all in one sentence or one little section. Then I go into, abdomen. The abdomen is soft and non-tender. Pupils are pearl, blah, 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 blah. So I go through and like I said, I'll post one of mine just so you can kind of see it. But I can literally write that on a piece of paper right now and insert any patient that I run into today, and I can fill in the blanks based on what they tell me. And that, again, that's kind of the goal here. So you get to the treatment, which is RX for prescription or treatment. This is physically what you did pharmacologically or otherwise. So you gave them oxygen. We gave them nitro, we gave them aspirin. And a lot of times the proper documentation for this is going to be doses. So it's easy to say, you know, I gave 1 sublingual nitro tablet. Well, that's cool. I know exactly what that means because nitro doesn't necessarily come in any other doses. This is the most common dose. So, you know, 0.4 milligrams of nitro is kind of redundant, except it's required. If you're going to document that you gave medication, you should document how much. Now, this goes back to the other question of, you know, if it's documented elsewhere, do I need to put it in here? Or can I just say, you know, we gave nitro? And that's personal and department preference. But again, if you're reading a report, I don't want to sit on the fire investigation side. I've sat and been cross-examined, and that is the worst thing in the world. And if it's not all right here in front of you, and there's any delay whatsoever, that opens up the door for, well, what do you mean? I thought you wrote this. Well, if you wrote this, why do you not remember? Why do you have to go back? And just trying to explain to them that, well, it was a year ago, and you know, whatever, down the list, there's a bunch of justifications. But if your report is here and 100% of what you did is physically here, you don't have to flip through a report. It's all right here. So just some things to think about. When you get into transport, we transported to, you know, whatever Mercy Fairfield Hospital. Transport was uneventful. I called the ER staff on the way, and then patient care was transferred to the ED staff. So again, this to me is the cleanest way to do these, because again, it kind of sets apart all of the important pieces of the puzzle. So that's just again, that's personal preference. So chart method, SOAP method, those are probably the top 2 templates, and then chronological would probably come right behind that for popularity. When you're going through trauma, so under the assessment, either the objective or in SOAP or the actual assessment part of the chart method, we head to toe. When you guys do your trauma exam, when you did your trauma patient assessment for EMT class, if you think about that, literally that sheet goes from head to toe. For the medic side, it's going to be the exact same thing. It's just we're going to add some stuff. So, you know, head to toe, you know, you feel the head. Is there fluid coming from the ears? If there is, what kind of fluid is it? You know, stuff like that. So we're going to add a little bit. If the trachea is not midline, we always said, you know, we're going to check, make sure the trachea is midline and there's no jugular vein distension. Those are things that we talked about as an EMT. As a medic, when you notice that, you have to kind of be able to put together why it's doing that. So, you know, whether it's you know, something to do with the heart, or whether it's something to do with, you know, whatever it is. So for us to be able to document that in a head to toe fashion is pretty important. The most important part of this are the last 2. The pertinent negatives, those are really, really, really valuable. And those are really commonly forgotten. So, you know, a car wreck, if the patient if the patient hits a telephone pole or something head on, documenting whether or not there's bruising on the clavicle and the lower abdomen consistent with seatbelt marks literally changes 100% of the treatment at the hospitals. If you take a patient to any given hospital with seatbelt signs, that is immediately a trauma criteria. So that, now they may not take you to the trauma bay, but that is absolutely trauma criteria. So documenting that they do not have seatbelt marks is a really, really important thing for trying to paint a picture of this acuity. And then the spoken accounts, if the patient physically says something to you as crazy and as absurd as it is, for you to be able to say, well, no, I mean, the patient literally said this, that's pretty valuable for us. Legible, I'm going to kind of move through some of this pretty quickly. Timely. So some of the timely stuff, again, this is all procedural based. A lot of the hospitals, they want you to have that report done by the time you leave. And that's just not the case. We just don't do it. And even if we did it, it ties electronically, it'll tie into Epic or whatever their charting system in the hospital is. So the people that are actually administering care currently aren't going to see your report anyway. So just timely. I wouldn't let days go by in between. Abbreviations, there's a whole, we talked a little bit about abbreviations already, but abbreviations, there are acceptable ones and there's a rabbit hole of unacceptable ones. So just make sure, find somebody, me, whoever, to look at if you're going to use abbreviations to truly make sure you know you're using the appropriate ones. We know about the consequences of poor documentation. There's some legal stuff, reputation I'm not too worried about because we're all heroes. But that's about it. Seek help if needed. There is nothing. So when you get done with this class, you're going to be you're kind of be thrown to the wolves in a lot of departments, but you will also have some mentor for at least some period of time. Hopefully, that mentor is going to look over your shoulder and make sure your reports are good and make sure your skills are where they should be for your department. Don't hesitate to take that person aside and say, hey, make sure this is good. I know what I'm supposed to be doing, but make sure this is actually appropriate for our department. Don't lie on a report. I don't want to get too deep into any of that because I think we know that. So I'm skipping through some of this. And times. Times are important for a bunch of reasons. The big thing with times is we are under NFPA guidelines. We are required to meet certain benchmarks. Those benchmarks transfer into more of a rating through insurance companies for our department's ISO rating. Not super important to understand any of that. Just know that times are really, really important for us. We need to be able to get out the door quickly and get on scene within so many minutes. And that opens up, that can open up funding for the department. That can open up a whole bunch of other things. So trying to keep track of times and making sure those are appropriate times is pretty important. That's really all I want to cover with this. So again, the chart method and the SOAP method and HIPAA stuff, that's pretty much the basis of kind of what I'm looking for here. Does anybody have any questions on that? Nothing? Well, that's good. That's real good. Okay, so here's what we're going to do. I'm going to start opening something else on my end to open the proctoring system for this exam. We're going to take a break, get your head right, get you some coffee. We're going to take this practice exam. Again, there's 40 questions. You guys will have about an hour or so. You guys might not need the full hour, but I will certainly allocate as much time as needed for that. If you guys, when you're done, just kind of take a break, do your thing, but try to stay within earshot if you can of the computer, so that when we're all back, we can kind of get rolling in the next thing. As a whole, if everybody does pretty good on this, we'll effectively be back pretty much on track for where we should be, despite me missing that day for quarantine. So this will put us back on track. If it's one or two people that don't do well on this, we will, like I said, I'm going to remediate, and then you guys will take it again sometime between now and the next class day. Probably I'll meet with you, or you guys, I'll set it up with you guys if you don't do well. If you don't do well, just shake it off. We'll roll through. We'll make it work. But the goal is really to get us back on track today, and that's kind of what this is going to do. So if you guys take a break, when you get back, jump into Schoology. There is a. I'm sorry. Was there a question?
I just. Oh, sorry. Go ahead.
So say only one or two don't do good. Do they only have to take it again, or does the whole class take it together?
If we have to do a retest, because this is going to go towards, chances are this particular exam probably won't go heavily into your GPA, because first and foremost, I don't expect everybody to do super awesome on the first one. And the other thing is, if you studied really hard the last few days and you end up with like a 78, that's technically a pass, but that's not gonna help you very much. Where if you fail it, I give you a second chance, and when you get a second chance, you could probably increase your grade. So it's not necessarily fair to those that passed the first time. So I'll find a way to make it work so that it's fair for everybody. But if you do not pass, or no matter what, if you feel like if everybody does well and we move forward from today, we're just going to leave it alone. If somebody has to retest, I'll give the option to everybody to retest if you so choose. But again, I'm not going to weight this very heavily at all, because I want us to kind of get in a position where we kind of get just a feel for how this kind of stuff's going to work. So when you get back, you'll jump in section, again, there's an open folder for section 1 exam. You'll take it. Again, you'll have about an hour to do it. And that's about it. Any questions?
I have a question for Zach real quick. Zach, are you there?
Yes, sir.
So for the Google Hangout, do I just need to send you my Gmail? Is it?
Zach,
I think, yeah, you're muted.
My bad.
You're good.
I clicked off of the Hangout. I started the Hangout. All I need is your information, and I'll add you to the Hangout. It's rather non-invasive. I just need some sort of Hangout or Gmail, and you should-
Okay. Sweet. I'll send you my Gmail right now.
Anybody else have anything else? Nada. All right. Take like a 5-minute break. Get yourself together. Come on back. Do this section exam, and then when you're done, just kind of hang out. And as soon as everybody's done, I'll jump back in. All right. So let's get into this. So patient assessment. This is the core of what we do. At the very basic, this is what is absolutely going to be required for you to do very, very, very well. If you do not do a good assessment, you're not going to get a good treatment. And if you're not going to give a good treatment, you're not going to have a good outcome. This is where we always say the best partner can be a good EMT, because an EMT is very, very good at this. Once you get down deep into like the differential stuff, that's where our brains are going to be spinning. We're going to be doing all this other stuff, and we're going to rely heavily on our EMTs to manage the airway, manage the breathing, and manage the circulation while you get your head together and figure out what a good patient assessment for this patient is going to be. We're going to start shifting gears. Like I keep saying it, and this is where we really start getting serious about it. We are thinking at a different level now. You can do this today when you leave. You can start using this. When you see these patients, you're going to start using this. Start thinking about this stuff. The term differential diagnosis is going to come up a lot. That is something that's really, really, really important for us to be able to fully understand, because that is at the core. That is when we're trying to decide what the problem is. And then we're trying to compare that to 3 or 4 other things that could create the same problem. And then we have to try to start removing things. So we have to start scratching stuff off. So when you get dispatched for trouble breathing, right now, pretty much what you're thinking, we're going to walk out to the ambulance, make sure I have oxygen. If they're not breathing, I'm going to bag for them. When we get there, we're going to see what the deal is. And right now you might be adding like fever and cough and COVID stuff. But so your differential while you're driving to a scene for trouble breathing is, it could be, what could it be? Well, it could be asthma. It could be COPD. It could be congestive heart failure. It could be all this other stuff that you've heard about and you kind of know what it is. It's that thing that we read about a long time ago. They might need a breathing treatment, but kind of why or what would lead us to that. So once we get there, we've got in our head, we've got COPD, we've got asthma, we've got fever, we've got all of these pneumonia, we've got all of these things that your brain automatically goes to. Once we get there, if they tell you that they're not febrile, they do not have a fever, you can start crossing stuff off. Well, maybe COVID's off the list, and maybe pneumonia is off the list, and maybe a viral infection is off the list. So you can start scratching stuff off. And our job is to get to a good, solid 2 or 3 things that we can truly work off of and start treating. And we'll start to realize soon that a lot of these diseases that we run on a regular basis, a lot of these diseases, the treatment pathway is pretty much the same. So, if they have wheezes, then we have to open them up and we have to give them that beta-2 agonist. We have to give them that albuterol or that Duoneb or whatever the medication is that we carry for nebulizers. We would have to give that to open them up. Well, that could be because of asthma or because of COPD or because of emphysema or some of these others. So at the end of the day, we may not know exactly which one it is, but we know what category it falls in so that we can appropriately treat it. And that's kind of what our goal is going to be. So quickly find it, set priorities based on whether or not the patient is really sick or really not sick. We have to come up with some kind of care plan and then figure out a way to execute and reevaluate it. And that can be just by simply taking vitals. So the first one is sick or not sick? And this is something that you could probably do from the doorway, and you could probably do it very well today. The problem that we run into is once we get into like pediatrics, we don't run on pediatric kids very often. So when you have a kid, immediately we err on the side of, well, this is sick because I'm not comfortable with this. And that's not, that's me included. That's most of us. So sick or not sick is basically just a general impression that we get based on a couple different criteria. So what is their chief complaint? Have they had this problem before? Are they breathing appropriately? Do they have a patent airway? Like those are all things, mental status. These are all things that kind of play into whether or not this patient is sick or not sick. Trauma patients, when we're talking about the mechanism of injury, we're going to talk a lot about the difference between that and the nature of illness. But the mechanism of injury, if it's a 60-mile-an-hour crash, I'm more concerned about that than the fender bender where somebody let off the brake at a stoplight and rear-ended somebody. So a lot of that stuff plays into whether or not you think your patient is sick or not sick. So you take all of this information, sick, not sick, and you start to formulate this whole field impression thing. So what is a field impression? It's literally a determination of what you think the patient's current problem is. So it's a neck injury because of a car wreck. It's they have history of asthma. So it's, this is a shortness of breath because of asthma or secondary to asthma or COPD or, or whatever it is. And then as a paramedic, we have to take that information and we have to start asking the questions to try to hone in on which one of these differential diagnoses it's going to be. And that's pretty much, in a nutshell, that's pretty much it. So part of this, we have to determine whether or not we're dealing with a medical patient or a trauma patient. Trauma patients, as far as acute life threats, the things we're worried about, fractures that impede breathing, fractures that basically increase bleeding, pelvic fractures, any immediate life threats as it relates to bleeding or ABC stuff. So that's really what we're trying to do. So with the medical patients, we have a lot more time to ask questions. In fact, we have to ask a little bit more. We have to try to dig into, do you have cardiac history? Do you have asthma? Do you have all these other things? And then as far as the trauma patient is concerned, they may also have a medical problem that led to this. So part of our treatment is to determine whether or not the diabetic that just crashed into the pole is having a diabetic issue or truly just lost control of the vehicle and hit a pole. And that's where, again, this complex level of thinking starts to come in. The diabetic patient that had a hypoglycemic event that then crashed into the pole, that's something that a lot of people would miss because we're not thinking for the unconscious trauma patient, we're not thinking check a blood sugar, or the seizure patient that had a seizure, or the epileptic, they had a seizure, then they crashed into the pole. Those are things that we have to start thinking about now. If we can fix the sugar, they might regain consciousness and tell us that they're not actually hurt, but we're thinking head injury and spinal injury and neurological devastation and stuff like that because they're not responding to us when really it's just something as simple as sugar. So all of this is going to start with this scene size up. And we talk about this in every single chapter to the point where I'm going to start skipping it. We know that scene safety is number one. 100% it is number one. It's always going to be number one. So following that, we determine the mechanism of injury or the nature of illness. And if this sounds a little bit like a National Registry sheet, it's because it is. This is exactly what we do for the National Registry sheets. And we're going to do this for every one of our patient assessments. So is the scene safe? Do I have enough people? What is the mechanism of injury? What is the nature of illness? Again, the standard precautions, the PPE, which looks graphically different now than it did 3 months ago, but standard PPE now could be an N95 with goggles or some kind of eye protection with maybe a gown with God knows what at this point. So standard precautions can mean a whole lot of different things. And then the number of patients. So is this car wreck, is this truly the only occupant, or was there an occupant in the passenger seat that was ejected and is now in the wood line? Those are the things that you have to start thinking about as far as a big picture is concerned. And then once you figure out the big picture, then you can start kind of honing in on that one specific part of the primary assessment or the primary survey of the patient. So when we get there, not even when we get there, but when we're dispatched, a lot of it is just kind of looking around, making sure our people are safe, specifically our newer people. Our newer people get the tunnel vision just as badly as you guys will. And I promise you, it's going to happen. It happens to all of us. So, you get the tunnel vision, you've got all of these algorithms and all these protocols and all this stuff in your mind. And at a certain point, you guys are going to look around and just go, what in the hell do I do? And that's normal. That truly is, as scary as that sounds, that is normal. It's normal for a lot of people to start looking to you because you guys are the doctors now. They're looking at you to determine whether or not we should move forward with a treatment, or what are we doing? What should we be doing? And quite frankly, in just a few months, maybe a little more, but in just a little while, you guys are going to be the reason these ambulances are called medic units. And that's a pretty big thing. So just making sure that we can try to take a back step, we can try to slow down just a little bit, and that we can look at a scene from the sky and say, all right, it looks like I've got about 7 patients or whatever it is. What resources do I need? How many people do I need? And then I need some kind of command assistance. I need somebody to take command so that I can start focusing on a patient, and then the next people can worry about the next patient. But you have to try to hone in on just that one thing that you're supposed to be doing. But it always has to start with the big picture. So we know that it's pretty much this is a team sport. So anything that's noticed by anybody, somebody's going to speak up at some point, and then we're going to try to do our best to minimize that. So traffic, trying to put a fire truck out there to block us for traffic, for car wrecks. Trying to bring police with us when something just doesn't sound or feel right, stuff like that. And it all takes a constant reassessment. We're going to keep looking at that. You get messes like this. And again, Liberty, I can speak a lot for them, but I can also speak for small suburbia, Delhi, and some of the other places that I've worked over the years. There's a lot of highway, specifically in Liberty, and some of the highway wrecks that we get, for God's sakes, we have one of the straightest pieces of 75 in the entire country, and great visibility. If you're familiar, like between 129 and State Route 63, where the outlet malls are, it is like the straightest, most visible area in the world. And somehow we have people that just make stupid choices and end up getting stupid prizes. And I hate to say it and I hate to think about it, but my goodness, it's not like it's a bend or a turn or a hill or something like that where visibility sucks. People just think it's an Autobahn. They 150 miles an hour, and wrecks like this aren't uncommon for us. And when you have a wreck at highway speeds, that obviously that starts to increase your concern for that high mechanism of injury that we're talking about. So trying to block the area, wear PPE appropriately. On the left, the guys in the black gear, City of Hamilton, there's a lot of places that have dark gear. That dark gear is very, very low on the reflectivity scale. Those yellow stripes, they may be a little bit reflective, but that's usually not super awesome. And that's evident by the amount of crashes that we have on highway, where there's a giant fire truck with flashies all over it that still get blasted on the highway. So sometimes it's really, really difficult. So try to stack the odds in your favor. So wear all the reflective gear, have the trucks that block the area, and don't get out of the ambulance until you truly have a safe scene for you to go out and function. If it's some type of physical violence of any kind, we know that we're going to stage, and that means stage somewhere far away, out of sight, out of mind. I hope this is not any of us, unless you work at a specialty department, to have to wear this kind of stuff. If you're here, you've probably made a wrong turn somewhere. You should probably be somewhere else. This is a specialty type situation, but we do have to pay attention to wind direction and some of the toxic stuff that can come from like tanker rollovers and train car issues and derailments. And for that matter, nowadays it's not uncommon to stumble upon like a one pot, like a meth lab, like a rolling mobile meth lab in a trunk of a car that has chemicals that may need this type of response from somebody. Crime scenes are going to be huge for us to know where our place, but we have to identify it. So, you show up and you know that something is not right here. This person is bleeding all over the place and it doesn't appear to be like a basic fall. Everything there is evidence. These police officers are going to come in, they're going to do their thing, and they're going to ask you where you went and whether or not you trampled through all the evidence that they need to try to take. So as far as the crime scenes, if you know it's a crime scene and you know there's no immediate life threats, let these guys go in and do it. Let the law enforcement go in, tell you when it's safe to go in there. And in a perfect world, they will bring the patients out to you, specifically if there's somebody still on the loose that may have caused the problem. Environmental risks. This is all part of this is all your scene safety survey at the very beginning. What kind of additional resources are you going to need? Do you need a rope rescue team? Do you need to commandeer a golf cart because somebody had a heart attack somewhere in the back 9 of a golf course? All of these are real things. These happen. These are things to kind of think about. What do you need? I usually pride our profession in general on the ability to think way outside the box. There's a problem that shows up. If the problem was simple enough that the person up at the office could have figured out, they probably wouldn't have called 911. So we are that higher level for them. They're not sure what to do. There's somebody that's unconscious way back there somewhere. What do we need to do? Well, we either need to take our trucks and drive on their golf course, which hell, that might need to happen, but that might not be the best. Maybe we need a gator. Maybe we need to, again, commandeer a golf cart, a tractor with a trailer, whatever it is. We just have to try to think outside the box. And that's something that, like I said, generally speaking, our profession is very, very good at. And you also have usually more than just one or two brains that are on there thinking about this. So this run might have 4 or 5 people, and in the 4 or 5 people with varying levels of history in this profession, you're bound to come up with something that's going to work really well. All right. So write this down. MOI and NOI, mechanism of injury and nature of illness. This is what we're going to use to try to determine what our differential diagnoses are. We have to determine whether there was some weird outside force that caused some kind of damage to the body, or some combination of some nature of illness, which is more of your medical patient. So again, this is trauma versus medical. Now, a patient could technically have both. Again, the seizure and then the car wreck, or the hypoglycemic event and then the car wreck. So we know that these can kind of blend, but by and large, the top one is trauma. Nature of illness is going to be medical. So we started thinking about this stuff. So as we dig into this, depending on this is going to tie directly into the additional resources that we need. Again, do we need more people? Do we need to start worrying about the spinal mobilization? Is there carbon monoxide poisoning in the house? Is there, are there multiple people injured, or multiple people having some type of related illness? These are all trigger points for us to think about, well, maybe we shouldn't be there. Maybe we do need additional people, and maybe we need law enforcement. Maybe we need, some other specialty organization, the hazmat team or whatever it is. So as far as our precautions, so again, we got this good size up. We got this good idea of kind of how the scene's progressing. We know what the safety is. We know that we're going to put the right stuff on. Nowadays, we use more of this than not, and that bottom one is true. We're going to err on the side of caution. We're going to use as much as we need. Specifically at a bare minimum, I know right now our department, and this is department specific, but our department very specifically, eye protection, N95, and gloves are to be worn on every single run. Any patient with a fever, any patient with a cough, or any patient with respiratory distress, we have to wear a gown. That is an actual policy that we have. So, again, that's the sliding scale. That can be more, there can be less. And in true fashion, what ends up happening is, as a profession, we start running out of this stuff. So part of why we're not able to get back into the school quite so quickly was mentioned the other day. And that's that we donated a lot of this equipment to local first responders. Well, again, the problem with that is now that we need them to get back into the classroom, we've already donated them, and now we can't buy them. So we're working to get them from the government. But that's a whole, this is all kind of a sliding scale. So PPE, this can go as deep as you need it to go. And I don't want to take too much time on that. So any questions on PPE? Nothing. All right. So this is the primary survey. So we're going to use this basically to form our general impression of the patient. This is going to include all of the life threats that we're going to deal with. To do this, there's a couple different ways, but again, a lot of it is just talking to the patient. We have to try to explain this stuff to them, and they're going to try to tell us what's going on. There's a lot of words here that really can be summed up in the first 30 seconds of your encounter with the patient, and you can tell right away whether they're sick or not sick, whether they're breathing or not, and whether CPR is needed. So you can tell all of that stuff just by walking in the door. So there's a lot of words here, but all of this goes kind of into how we come to the decision on, what we're going to do with them. So again, these are the 3 different things that you're going to do. You're going to inspect. That's just a visual inspection. Palpation, again, pushing and prodding and trying to elicit a pain response. And auscultation is listening. So listening to lung sounds, listening to abdominal sounds, listening to heart sounds, which again, we probably won't do much of. But trying to find fetal tones. If there's a pregnant woman, there's a lot of different things that we can auscultate. So all of that will get us into our general impression, which is basically our initial presentation and chief complaint. That is what general impression is. That's pretty important for you to know for testing. So general impression, again, this is 100% based on initial presentation and the patient's chief complaint. So we've already established that a chief complaint is verbatim what the patient says to you. It's not what you think's going on. That is your provider's impression. That is your general impression. The chief complaint is something that physically is stated by the patient to you, and you can write it down verbatim. So from there, we have to start making these systemic observations. So, if they look sick, then we have to start asking the questions. Have you had this for a while? Does this feel like something you've had in the past? Do you have chest pain? Do you have trouble breathing? Are you nauseous? Are you vomiting? Do you have flu-like symptoms? All of that stuff can kind of help kind of hone us in on where we're trying to get to. And at the core of it, are they stable or are they not stable? Basically, are they sick or are they not sick? And that's really what we're trying to establish. So then if they are sick, how sick are they? So are they sick? Like, I need to bring 2 additional people in the ambulance with me? Do I need to get all my airway supplies together? What do I need to do? Do I need to go to a close hospital? Do I need to go to a more appropriate hospital that's a little further away with the appropriate resources? So these are all things that you have to kind of consider when you're starting to determine sick or not sick. But again, all of that starts after your safety with forming that general impression. Are they sick? Are they not sick? So we're going to talk to them. That's really what we're going to do. We're going to talk to them. We're just going to figure out a baseline as soon as we physically can, just by communicating with the patient. Step 1 is always to introduce yourself. You will see that again. Step 1 is always introduce yourself. Hi, I'm Adam. I'm a paramedic with blah, 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 blah. What's going on? Open-ended questions will let them talk to you. Obviously, the shorter breath patients probably have no interest in telling you a life story because they can't breathe. So that's a little different, but that's super important for me. It's super important for me to know, hey, he's not breathing well enough that he can speak in complete sentences. So that should trigger something to me that I need. Okay, this is not going well. He or she is sick. We need to go to a hospital quickly. I'm not going to sit and screw around on scene. We're going to load him up and we're going to get out of here. So what does that look like? Well, I got to get a cot in, and you have to start going through these priorities. So I need to get a cot in. I need to make sure I have oxygen ready. If that trouble breathing is truly starting to deteriorate and they're starting to get confused or whatever it is, I know that I might be bagging them. I might need to bring in some ventilatory assistance. So thinking about all that stuff as the paramedic provider, again, that is you. That is your job. You're going to be at the head of that patient, making all the calls. What do you need? How do you need to facilitate getting this patient outside? How many people do you need with you? Do you need a patient, or do you need a provider with you just for airway support? Do you need somebody with you just specifically in case something goes bad? Do you need a chaperone? Is it somebody of the opposite sex and you want to bring somebody with you? Is it a juvenile? Just for an extra set of eyes? These are all things that you're starting to consider while you're moving into the main algorithm of this. And that main algorithm is truly going to take us to those differentials. So it's going to take us from our general impression down to maybe a specific criteria or specific guideline that we can use in the protocol to say, okay, well, this is what we're going to do to treat this patient. So, and a lot of this has to do with considering, again, the questioning that we're asking the patients. We're considering the mechanism of injury, the nature of illness, whatever it is. So starting this process, so you're now at the head of the patient, and you can picture any patient that you've made runs on recently, in the house, on the floor, in the kitchen, whatever it is. As you're starting to ask the questions, are they talking to you? If they're talking to you, they have an open and patent airway. That's good. That's good. Are they breathing on their own? Well, they're communicating with us. So yes, they're breathing on their own. We don't know yet how effectively. We don't know if they're wheezing. We don't know any of that stuff. But what I do know is that the patient's breathing. And if the patient's answering my questions, they're oxygenating. We know that is actually working out. So I'm good with that. So far, so good. Are they bleeding all over the place? Okay, that's a life threat. If you identify any of those, any deviation from that, you treat that on the spot immediately. We don't move on. We don't go further into our assessment. We treat it immediately. This is going to be really, really important when we get into our practical skills. If you're going through, you're thinking algorithmically, you're thinking through that whole, that checklist and National Registry stuff. But when you come to the life threats and you ask me if there's any life threats, if you see a life threat, by God, you need to treat it. Treat it now. Don't wait. Stop the bleeding. Throw a tourniquet on. Start breathing. Start, whatever you have to do. Start CPR. That stuff has to happen as soon as you find it, as it relates to these life threats. We get right into that. And then obviously we decide our transport decision and where we're going. Some hospitals are better with trauma than others. Some hospitals I wouldn't take an animal to, and I'm not going to say it, but it sounds a lot like Hersey Harefield. There's a couple of these that I'm just not a big fan of. So just some thoughts. Mental status. Mental status is going to tell us a lot of information because again, they're ventilating, but are they oxygenating? Is there a respiration process going on? Are they actually taking oxygen in? So a lot of that stuff is pretty important. So trying to keep a good tab on the mental status is pretty important for us. So in the airway, are they talking? Is it open? Is it obstructed? Are there's definitely some indicators for us to know that something is not right with the airway. As it relates to kids, again, crying is great. I'm okay with crying. Crying means they're breathing. Crying means they're moving air. Who can tell me what sonorous respirations are? Bueller. Anybody? Sonorous respirations. Nobody.
Snoring.
There it is. Snoring. Thank you. Snoring respirations. Sonorous respirations mean snoring respirations. Please write that down. You'll probably need to see that later. Sonorous respirations. So sonorous respirations, that means that there's some type of obstruction in there. So there's something in the upper airway that's creating that snoring. It's usually the tongue. The tongue is one of the most common airway obstructions, specifically in adults. So there's some kind of airway obstruction. Maybe they need an OPA. Maybe they need some kind of breathing adjunct. Maybe it's just a positioning thing. So thinking about that this is all part of our airway management. If they're gurgling or bubbling or something, maybe they need suction. So this is all super, super important for us to be able to key in on immediately, because again, these are all life threats. And a majority of the time, this is a basic skill. A majority of the time, all of the life threats fall back to basic skills. So just EMT stuff, open the airway, suction the airway, breathe for somebody artificially, or ventilate them, CPR, all of this stuff. Again, this is right now we're still thinking about this as life threats. And when we're thinking about life threats, we're thinking about this as from the EMT basic perspective. And on that note, when you're taking tests, it's probably important for me to mention that if you're looking at this, you have to ultimately make decisions based as a medic, and you have to fully understand what you're saying. You got to know the words that are coming out of your mouth. But the first step is always going to be to treat these patients as an EMT would, because again, that is all part of these life threats. So when they're asking you questions and they give you the pH numbers and they give you all of this god awful stuff that you need an IV and you need drugs and you need all this other ALS level support stuff. If one of the questions has to do with opening an airway, or one of the questions seems to you like an EMT basic skill, it probably is, and it's probably the right answer. So some of the most critical stuff, that's why we train EMTs the way we train EMTs, because the most critical stuff, we want everybody to be able to manage appropriately. So thereafter, they can tag us in and we start doing the ALS stuff. But every patient we need to treat the patient as a basic first, because again, those are the life threats that we're trying to get in and intervene in. So this is more airway assessment. I'm pretty good with this, as long as you guys are. There's a question there. This is talking about the minute volume, which is essentially the respiratory rate. And that's multiplied by the tidal volume. So the tidal volume we know is how much air is physically moved into the lungs per ventilation cycle, or with each breath. And then over the course of 1 minute, that gives you your respiratory rate. That tells you what your minute volume is. None of that is going to help you do anything in the field. I promise. They're either breathing enough or they're not breathing enough. And if they're not breathing enough, we fix that by breathing for them. If they're breathing too quickly, once again, they are breathing off, if they're hyperventilating, they're breathing off all of their oxygen, they're breathing off all of their carbon dioxide. At a certain point, they're going to lose consciousness. They're going to hyperventilate and they're going to pass out. When they pass out, their body will self-correct the minute volume. A body is designed to do that. It will self-correct the breathing status. So you can only hyperventilate so long before you pass out. And again, your body will take over and fix that, because that homeostasis has to happen and the body knows that it needs to fix that. So it'll fix it by itself. there are times where we can ventilate, we can assist that. But again, that's a small window of patience. So some of the other stuff. So worker breathing. How hard are they working to get that air in? That's a pretty big deal. When they take a breath in, does both sides of the chest rise? Maybe only one side does, and that could indicate a problem. Maybe there are not lung sounds on one side. Maybe there's not lung sounds in the bases, and that could indicate like some type of pneumonia or something. So again, we're going to start listening, and when we do our assessments, there's multiple places that we're going to listen to make sure that we have adequate breathing. So we've got airway out of the way. This is really all you need to know about breathing. What is their rate? What is the quality? Are they working really, really hard? That's really it. So again, back to my report, patient is alert and oriented, GCS of 15. That gives me the mental status. So they're awake and able to communicate with me. Their airway is patent and self-managed. So I write that on every report because that tells everybody, including myself later, that I assessed their airway to make sure it's physically open and being managed by them. They're not snoring or anything. Their breathing is adequate. So, and I'll usually write that the breath sounds are equal bilaterally in all fields, or some variation of that with a decreased work of breathing. So they're not working hard. So I'll write that in. Then we move into C. So for circulation, we're just looking for life threats right now. We're looking for major hemorrhage. Do they have a pulse? Do they have distal pulses? Are they cool, pale, and diaphoretic? If they're cool, pale, and sweaty, or cool, pale, and diaphoretic, then that can indicate a shock problem. And that's all part of circulation because there's not enough circulation getting where it needs to go. So again, back to my report, breath sounds clear and equal in all fields. Skin is pink, warm, and dry. If it's pink, warm, and dry, that goes over the color, the temperature, the condition of the skin. That covers pretty much everything for me. As it relates to a trauma patient, if we've got a mechanism of injury there, I could put I can put something in there about external bleeding and whether or not I use a tourniquet and things like that. So again, basic. Are they bleeding all over the place, and do they have a pulse? So this is a review from EMT school. So how do you appreciate a pulse? So we're going to get into a little bit deeper the basic assessment stuff that you guys already know how to do. So again, if you can count the pulse and that you've got 40 beats in 30 seconds, you can simply multiply that by 2. So 40 times 2 is 80. So their pulse per minute is 80. This is a normal pulse. And I wish I could put air quotes out there for this, but a normal pulse for adults is 60 to 100. Fat people are probably closer to 100, and people that run for a living are probably closer to 50 or 60. So technically, by definition, under 60 is bradycardic, over 100 is tachycardic. There's another subsection for that once we start moving forward. There is a part of tachycardia where it becomes even more tachycardic, and there's a term for that, and there's a treatment for that. So, but at the very basic core, there's a fast rate, there's a slow rate, and there's a normal rate, and I think we're pretty much all there for that. So again, the pulse. Not only do we care now, again, higher level thinking, not only do we care that there is a pulse, but what does the pulse feel like? Is it weak and thready? The word thready is a term that's actually used quite often in the medical community in general. But if you reach down and you feel, and I like to say grandma, because grandma, there's always a thin, like real thin skin, kind of frail. The pulses are usually kind of hard to feel. You got to find them. Sometimes it's even difficult to find like a radial pulse on her. So, a weak pulse is difficult to feel it's usually considered thready. So that's weak, hard to feel. Usually it's kind of fast because they're just not, their body's just trying to compensate. So a weak pulse is typically thready. And then bounding would be that high blood pressure. So what does the pulse feel like to you? Fast, slow, regular, or irregular? And that's really what we're looking for. If it's irregular, there's a bunch of stuff that we have to now do. We have to start thinking about a 12 lead. We have to start trying to figure out why their heart is not beating regularly. And that's all stuff that we'll talk about later in cardiology. So then skin, these are the 3 things I'm really looking for. Just color, temperature, and condition. Get in a habit of documenting this stuff. Because again, if they're pale, cool, and dry, that's different than pale, hot, and dry. And all of that is different than pale, cool, and diaphoretic. So again, a baseline that I'd like to see is generally pink, warm, and dry. So they're not hot, they're not cold. Their skin condition is usually kind of a pink color. African American, a lot of times we use lips, we use somewhere in the capillary beds. And if all else fails, just in general, you can tell pale from not pale, even despite any different skin pigmentation. And then condition, is it wet, dry? What is the physical condition of it? So start getting in a habit now of documenting that, because that truly is going to start dictating treatments moving forward. So as far as further circulation stuff, these are some of the options that we just kind of talked about. Some of this is kind of interesting, but it's not necessarily needed for us. Understanding that flushed and red are synonymous, blue and cyanotic, those are synonymous. So we're not usually at this level, we're not going to document that the skin looked blue. The skin was cyanotic. Modeling is a really, really important thing that we'll get into later, but modeling is like the blotches. So if there's like blotches or patches of like red or different discolorations, that's a pretty big indicator of a problem. Jaundice is like a yellow color. You'll know that as soon as you see it. If you go on a 12-hour bender at the bar, you wake up the next morning and look in the mirror and your eyes are kind of yellow, that's your liver pissed off. That's exactly what that is. So liver dysfunction, that can be temporary. So, again, the bender at the bar, you wake up and you see a little bit of yellow or a little bit of kind of a dull kind of yellowy color in your eyes. That's your liver just getting pissed off at you. Skin, again, these are some of the options. We know that warm and dry or hot and dry can be fever. And again, if it's 100 degrees outside and they're cutting grass, I'm going to expect them to be diaphoretic, but I'm also going to document that. It was warm outside. The patient was cool, pale, and diaphoretic. That's one of those circumstances that can mimic a shock. If they're cool, pale, and diaphoretic because they're outside cutting grass, or they're hot, pale, and diaphoretic because they're cutting grass, that's a normal finding, although it's abnormal in general. So once you notice there's a problem, we have to try to fix it. So we stop the bleeding. We tourniquet it. We do what we have to do. We stop bleeding. We circulate their heart for them if they're not breathing, if it's not beating. So we do the CPR. Manual defibrillation. This is us hooking them to our monitor, looking at it and going, oh God, that's not good, and shocking them. We're not relying on the AEDs anymore because, again, we're thinking at a higher level. We know what the AED is supposed to be looking for. So once we get into cardiology, you will know these are the two rhythms that the AED is looking for. We know that when we see them on the monitor, we're going to manually defibrillate this patient ourselves. And again, it's all just to restore circulation. Let's take about 10 minutes and let some of this kind of digest. Come up with some questions if you have it, and get you some coffee, do your thing, and I will be back in about 10 minutes. Okay, so AVPU, what is AVPU? Cody, what is AVPU?
If the patient is alert of verbal, pain, and unresponsive.
That is 100% correct. So that is a good way for us to just basically get a down dirty, are they neurologically appropriate or not? And it's just quick. It's just a quick down dirty way to do it. Glasgow coma score. We're going to talk about this a little bit in trauma. There's no C. It's not a cow. It's Glasgow with a G. And that is basically our way of trying to explain or determine how significant of a trauma the patient may have had. So GCS is related to trauma almost exclusively. So if you see a question about GCS, this is going to be pretty prevalent in the trauma communication. We'll talk a little bit more kind of about that moving forward. The one thing I need you to know is that GCS, the max is 15 and the minimum is 3. You cannot document a 0. You cannot document a 1 or a 2 because the minimum is 3. Right now, Abraham Lincoln has a GCS of 3. So don't ever document less than a 3 and never over 15. I will also say that some of the docs now, they're not a super big fan of GCS in general, because if I told them the GCS is supposed to be 15, but if I told them it's 11, that doesn't necessarily tell them what's wrong. That doesn't, maybe the patient by nature, maybe the patient's a trach patient and doesn't have the ability to speak. And if they don't have the ability to speak, then they can't communicate with me. So they may get the GCS score might suffer a little bit because they can't functionally communicate with me. That doesn't mean that there's a problem. That just means that they don't have the ability. So that doesn't tell them what the disability is. So just know that there's a limitation to it, but widely it is still accepted. So we're still going to use it. So we're just looking for just kind of gross neurologic deficits. Can they move? Can they walk? Do they have good grip strength? A lot of this is starting to sound a lot like stroke assessments, because that's exactly what this is. This is a stroke assessment, and that's basically when we're going to use it. So can they feel? Do they feel pain if you pinch them? Do they feel temperature? Do they have grip strength? And again, this is a little bit more invasive or more in depth than the basic stroke assessment. But this can also be used after a car wreck. A patient has significant back pain and can't feel his feet. Well, that's a big deal. So is it just the feet? Can you feel temperature to the legs? Can you feel movement? Do you feel me touching? Can you lift your leg? Can you move your leg? Again, a lot of this doesn't necessarily assist us in better treating the patient, other than trying to prevent any further damage by backboarding them and C-collaring them and stuff like that. It's not going to change our treatment path per se, but it is going to allow us to identify that there is a significant mechanism of injury that's resulted in some kind of neurological deficit. And all of that means that we need to go to a more appropriate facility. So when we start talking about the appropriateness of one hospital versus another, this is where we get some of that information. So, and the last one is basically us just trying to go through and again, this expose and cover. A lot of this is the trauma. There's the no modesty in EMS that I always talk about, and that's that we have to be able to see the exposed skin, or exposed skin, and we have to be able to then preserve some kind of modesty if we can by putting a blanket or something back on them. So transport decision, we know that we've kind of determined, based on our general impression, we've determined that it's a sick or not sick patient. The sick or not sick, if they are sick, how sick, and if they're really sick, then we need to go to some appropriate facility that may be closer than another. If airway is going to be a problem, then we know we need to get to a hospital right now. I don't want to be screwing around with airway management, on the fly in the back of an ambulance bumping down the road. If I know that the airway is going to be a problem early, there's nothing that says I can't take the airway early and intubate them, or whatever it is. Have precautions with me. Have another person with me to get them to an appropriate facility. But at the end of the day, if any of the ABCs are not able to be managed by you, then obviously we're going to go to a close place. So here's some examples of the priority patients. A lot of this is the whole that if the general, again, your general impression leads you to say, this sucks, there's a problem, hair on the back of your neck stands up, you feel nervous, you feel anxious, all of this stuff, all of that goes into your decision making for this. If you're a relatively new medic and you're with a relatively new EMT, or relatively young limited experience EMT, this might be exaggerated a little bit. You might, your first couple critical patients where you're literally the person in charge of the run, any one of these is truly this can be nerve-wracking. We're always going to fall back, all the neat stuff and the tools and all the stuff that we're going to learn in this class. At the end of all of it, if you don't remember any of it, we remember A, B, and C. You can still be a basic. You can still treat the patient. If you don't have enough hands to do an IV and all this other monitoring and all the other stuff plus airway, if you can't do all of that stuff, you limit yourself to what you can physically do. You can't spread yourself too thin. You do your airway, then you do your breathing. If you don't get to if you get to circulation, just make sure that they're not bleeding all over the place. You can control that and go back to A and B. You can only do what you can do. And if you have to prioritize, you prioritize alphabetically there, A, B, then C. And again, C is the weird one because you can throw a tourniquet on and go right back to A and B. So this is just kind of just a quick splash of some of this stuff. But unresponsive patients, just in general, there's a whole bunch of them that can give you that general impression that there's something that's just not super good. All right, so that's your primary survey. Once you're done with that, and not before, once you're done with all the primary stuff, so once you're done with life threats and A, B, C, D, and sometimes E, if you're the type that looks into like the environmental stuff, if you're good with the A, B, C, and D and the life threats, then we move into history taking. Now, history taking of an unconscious patient is useless other than trying to consult with the family or bystanders or witnesses or whatever. History of a trauma patient is very, very specific. I don't necessarily care that they had ear tubes placed 25 years ago. What I care about is, why did you wreck your car? And do you know where you're at? Do you know what's going on today? Do you feel your legs? Do you feel everything? And again, all that's after the ABCD. So the OPQRST and the sample. Somebody give me the OPQRST. What is OPQRST?
Onset, provocation, quality, radiation, severe, time.
That's exactly it. Somebody else give me sample.
Signs and symptoms, allergies, medication, past pertinent history, last oral intake, and events leading.
That's exactly it. So we're going to start expanding on that. When you expand on that, specifically in the medic world, once we start expanding on that, what that's going to lead us to is our nature of illness. So we're going to use that to determine which one of our differentials is correct. So the history could not be more important for us when we're trying to figure out that specific nature of illness that we're looking for. So in general, this is probably something pretty important to understand. In general, the whole purpose of this is just to gain information somewhat in chronological order of the events surrounding this particular incident. So if I told you very specifically that this whole pertinent medical history as it relates to this, if there was a test question, which there probably will be, very specifically, it is the whole point of this is to gain information in a chronological order of the events that relate specifically to this. So when did your chest pain start? You know, while I was cutting grass. Okay, what does it feel like? Have you had this pain before? And then you can start going through your sample history or your OPQRST. You're going to ultimately end up doing both. It is important to know that, you know, I had a patient in a very HIPAA compliant way. I had a patient a couple of days ago that said that he was having chest pain. Well, have you ever had this chest pain before? Well, yeah, it feels like the last 7 heart attacks I've had. 7 heart attacks. So this feels just like it. Well, there's that hair on the back of your neck going, oh, well, he knows. He's clearly been through this. This isn't his first rodeo. 7 previous cardiac events. We're on number 8. And he's like, this feels exactly like the first 7. Well, there's your clue. That's a pretty simple tip off. So the open-ended questions, you know, what does this feel like? Don't say, does this feel sharp or stabbing? Does it feel dull? No, let them describe it to you. Let them describe it with their words to you. And then try not to say exactly what I said. You know, does this feel like your last one? That's a leading question. Now, I can argue that that's a pretty relevant one, but if I say, hey, does this feel like a heart attack? And the patient's never had a heart attack before, that's a leading question that's not going to give you a good result. Age-appropriate questions, that's basically the asking a kid if he has cardiac history. You know, an 8-year-old doesn't have any idea what that means. So be patient. This is a bad day for them. So chief complaint, we know that as far as the patient information is concerned, the name in their chief complaint is, and I would argue that really it's just chief complaint that's the most important piece of this. What is wrong? If they pass out in 30 seconds, what is the one piece of information that you absolutely have to have right now before you can proceed? Unconscious people are usually super simple patients. They can't argue with you. They can't complain. You literally have nothing but objective things to treat. So you put them on a monitor, you treat it. You give them fluid, you treat it. You take their vitals, you treat them. When it's objective, that's really, really easy. It's when they start telling you all this other stuff. I'm short of breath and I have all these allergies and I got all these problems and I have fibromyalgia and my fingers hurt and I eat 4 food. All of that stuff just muddies the water. So a basic chief complaint is really where I need to go with it. That is my starting point. What is wrong? You tell me what's wrong, and then I'll start asking questions based on that. Does that make sense? I hope. Good. Techniques. So you guys are going to struggle with this, and I've said it before. You guys are really going to struggle, not necessarily with the appearance. You're not going to really struggle with any of the note-taking stuff. This is where you're going to communicate. This is your problem right here, is the communication. Because in your head, you're going to have all this stuff that you have to do, all these algorithms, and you're going to really, really struggle to talk to the patient in a manner that the patient fully understands you, while trying to conduct some kind of interview here to determine what you need to do to treat them. They don't necessarily need to know all the $4 words that you guys know. They don't necessarily need to know, okay, I'm going to take this needle, I'm going to stick it in your arm, I'm going to slide off this plastic catheter, and then I'm going to tape it down. But you have to be able to talk about something to kind of have that interpersonal communication between the patient. It's really hard to do that and to talk about how terrible our sports teams in Cincinnati are while telling them, or while doing something completely different like an IV start. So that's a really, really difficult thing for us to do. It's really hard for us to, in our head, transcribe, how do you feel? Well, I feel poorly. Well, what does poorly mean to you? And they start saying, I feel like I'm all sweaty and I get these hot flashes. And so they're using all those words, and you have to translate that into your notes as they're pale and they're diaphoretic. They have shortness of breath. They have shortness of breath that gets worse when they move. When you start actually documenting that on your own, especially in your notes, it's hard to translate that to something that's of medical soundness while trying to communicate with them in street terminology. So that's all stuff that it's kind of an acquired thing that you guys will get eventually. But the number one thing, the first thing that you do, again, is introduce yourself to the patient. That is the very first piece of communication. That's the very first thing you do. And again, that will be a test question. But first thing you do when you're talking to a patient is you introduce yourself. Very simple. Try to be empathetic. Try to have a little bit of compassion. Reassurance is kind of a weird word because you can't necessarily tell the patient they're going to be okay, because you don't truly know that. You can't tell them something that you think is going to be true, knowing that there could be a different outcome, like you're going to be fine. You get to the hospital and they get some kind of alternate news. That's kind of tough. So just try to stay positive. Try to tell them that you're doing the best you can. This is I'll tell you every step of the way. No surprises. I usually will say something along them lines in the back of an ambulance. No surprises for me. I'll tell you before I do anything, and then start asking your history questions. The OPQRST is a great starting point for that. We're going to skip through some of this stuff. Social history, I don't care at all about, because that's not going to necessarily help me do anything. So when I'm asking questions, I'm going to kind of avoid this stuff. I'm going to look for some of the only social history at this point that I care about is the travel. Have you traveled recently? Have you been exposed recently? Do you have a fever? And I'm going to ask some very specific questions about their social group. Is there anybody in your family that's been sick or ill, flu-like symptoms? So those are all questions that I will ask as it relates to their social history. But otherwise, I don't particularly care. As far as other sensitive topics that we have to ask about, drug and alcohol, we know that alcohol can mask signs and symptoms. Again, test question. Alcohol is a tough thing for us to try to evaluate or try to gain a general impression when they're drunk or high. It's just tough because they can't communicate with us as effectively as we would otherwise want them to. Now, this is also a super fine line, and I guess this is a pretty good time to mention it. It's a fine line for us to be able to say the patient was drunk. You are not a doctor. You are not a police officer that's trained in the detection of alcohol. So it's really, really difficult for us in the EMS world to document that the patient was drunk. If the patient says he's drunk or she's drunk, then yes, you can write it, because again, that's something that they physically said to you. But what we're looking for is that fruity odor, that smell of alcohol. We probably all smell it. That would give us the indication that maybe there is a problem. And really, at the end of it, when we document it, patient was potentially altered due to the smell of an alcoholic beverage, or due to saying that they left the bar, or due to you found beer cans on the floorboard of the car and you had the weird odor. And if all else fails, again, you can't use the word drunk. Don't use the word drunk. You can ask the police officer that may or may not be on scene. You would ask them, would you suspect that this person's impaired? Are you going to let this person drive away from the scene? Are you okay with that? If they say no, then you literally just document that. So this is kind of a weird, kind of a muddy area for us to try to not say that they were drunk, because again, we're not really trained to determine whether or not they are. Skip kind of ahead to domestic violence when we're trying to document this stuff. This is tough. This is a super, super scary. This picture right here is a perfect example of somewhere where we should probably not be. Domestic violence, that's one of the highest law enforcement injuries as far as calls, secondary only to car wrecks. This is pretty big because, again, those two are clearly having some type of altercation, but there's a third-party person that's now intervening and getting into the business of the other two. And at that point, they automatically, even in the worst arguments, a lot of times the anger and the hostility turns towards these invading people that aren't necessarily part of this conversation. So domestic violence is a pretty scary thing. In addition, they're in their house frequently. They know where weapons are. They have kitchens. They have knives. They have stuff. They have stuff that we need to not be any part of. So as it relates to domestic violence, you will always want to stage for this. I don't care if there's non-breathers. I don't care what's going on inside. If this is some kind of case of violence in any way, shape, or form, you're going to stage outside and you're going to wait. Some departments, they generally, and like Hamilton is a good example, on a regular basis, in the city of Cincinnati for that matter, they frequently get themselves into positions where they're calling for help on the radio. Again, that is too far. They physically went too far into that scene before waiting for law enforcement. So kind of keep that in mind. Don't put yourself in that position if you can help it. And if it goes bad, get out. Really, that's what it comes down to. You drop everything you're doing and get out. There was a question on today's. I think it was today's. I'm sorry, it's going to be on the next one. There's going to be a question about if the scene or if somebody starts yelling at you or becoming hostile towards you. You don't have to take that. You don't have to just say, "Oh, that's okay. I understand that." You can say very specifically, "You don't talk to me like that." If keep your tone appropriate, or I have to get law enforcement involved. Something as simple as that. That is less confrontational than you just saying, "Okay, you're going to be a jerk. I'm going to get my shit. I'm getting out." That's less confrontational than telling them, getting into a full-blown argument with them. Stop, this is ridiculous, and confronting them on it. You can say, "Hey, let's keep this professional, or I have to get law enforcement involved." And that's a very, very appropriate way to say it. And if they still continue to be hostile towards you, then you get out. But frequently the law enforcement, they know the addresses, they're familiar. And a lot of times they're with you anyway. So I wouldn't worry too much about that. Confidentiality, I'm going to breeze through. We know that HIPAA laws are out there. We're just not going to communicate. We're not going to talk about their stuff. They have the same expectation of privacy that you would. So, if it's a 17-year-old, and I like to use a 16 or 17-year-old female that's having abdominal pain, that you suspect that she's sexually active. When you start thinking about that, she may or may not want anything to do with her parents knowing. So having that conversation in private is probably going to be pretty important for you. If you don't, then she's not going to feel comfortable talking to you. And if she doesn't feel comfortable talking to you, she's just going to deny everything. And that's not necessarily helpful for her either. So specifically, if there's a problem or complication with the pregnancy, she may need to be seen. So just trying to maintain that private, that little privacy that everybody kind of expects is going to be important. So third party, so you got your unconscious patient. Just hit a telephone pole. What do you do? Where do you get information? That is going to be super, super frustrating for you guys when you get into testing. So if I give you a patient, the patient's unresponsive following whatever, a trauma, you're going through your national registry sheet, you're going through your little checklist, and you know that you got to get all the points. You get to the sample history or the OPQRST. Well, the patient's unconscious. I can't give you any guidance because I'm the proctor at that point. So what do you do? Well, the answer to that is you're looking around to try to find somebody that can give you some information. Did this patient do you know if did he strike something else ahead of time? Do you know if there's somebody in the car? Do you know that does he have seizure history? Is she diabetic? You can ask people, you can ask bystanders. Chances are if the patient's unresponsive, I'm going to tell you there are no bystanders. And that's fine. You got credit because you looked around, you tried to figure out if there was a family member or somebody that can give you some type of information that would lead you to how you need to treat this patient. So third parties, that's kind of tough because again, they don't know. And if you ask 5 people the same 5 questions, you're going to get 5 completely different answers. And that is the world of a dispatcher. So, you know, when we get dispatched to some of these crazy scenes that are nothing like what they, you know, like the picture they painted, this is why they're trying to put together 3 or 4 different people's interpretations of what happened. And it's tough. It's that weird telephone game. So it doesn't necessarily work super, super awesome. We talked a little bit about the cultural differences. Everybody, as far as communication barriers, some people like to be referred as something different, race, all of this stuff. As it relates to gender, age, race, and that's about it. So yeah, race, age, gender. Those are 3 reportable items. So the state of Ohio typically wants to know about that. Now, some departments have started to get away from the race because there's a good blend of you know what percentages and which one is priority and primary, and so they're starting to kind of get away from that. As it relates to gender, that's a tough one. Anatomically or biologically, that's what we're kind of concerned about. If it's somebody that has some abdominal pain and it's somebody that was a female that's now identifying as a male, that doesn't change the fact that there's still female anatomy that has to be evaluated. Cervical cancer and, you know, uterine cancer and other problems like that. So gender is a biological term, not necessarily a gender, so like a social identification. So again, biology is what prevails for this. So it's physically what parts they have and what parts they don't have. Hope that makes sense. Try to be respectful. Consent is going to be a big thing that we talk about a lot, and that's really all I want to go into with that specific stuff. Some of the challenges we know. So some of the challenges. So overly talkative patients, overly talkative or over like hyperactive patients. If they're pacing around the scene. And they're, you know, that can easily be some type of like a methamphetamine or some kind of overdose or some kind of stimulant patient. If they're just talkative because they're talkative, you can usually tell that. But if they're running around the house and they're shaking and they're talking a mile a minute and, you know, they're sweaty and they're a hot mess, you can tell right off the bat, like, oh, there's some drug influence here. If they're totally silent, they don't want to say a word, that can easily, in the psychology world, that could easily be kind of an abusive thing. They don't necessarily want to talk about it, or they're not in a good place. There's company in a room that they don't necessarily feel comfortable talking about stuff with. So stuff like that. As it relates to the injury, or I'm sorry, the anger and the hostility, again, we talked a lot about that. Get the law enforcement involved, and that's going to be the key indicator for that, or the key thing for that. Any bizarre behavior, all of this, just document it. Just write it down. If it feels unsafe, it probably is. Get out. Really, that's it. Some of the secondary English as a second language patients. So, you know, their Hispanic primary language is Spanish. Your conversation with them is going to be somewhat difficult. I can say very, very specifically, and I don't know if it's in this slide. No, it's not necessarily in this slide specifically. But pediatric patients in general, they are phenomenal translators. They're great. They're great at translating because they're exposed to English in school, which, by the way, is a test question. So if they're exposed to English in school, then that makes them that gives them that exposure to be able to translate for you. Now, again, that's not necessarily the most appropriate way to get a translator. Excuse me, but that's really that's going to be the best you have in a lot of circumstances, and that's okay. If you can get the kid to tell you what's going on, then you've got a pretty good idea of what your treatment pathways need to be. So with kids, if you're trying to assess the kid, and the kid, not the translation, but the child themselves is the problem. A lot of times they're not going to have any idea what their medical history is. Elderly people, a lot of times they have no idea what their specifically what their problems are. They just know that the doctor said take the red pill in the morning and the green pill at night, and that's really what they do, and they have no idea why. And that I wish I could say that wasn't common, but that is super, super common. That's just, it's what they do. And with kids, kids, you're trying to explain some stuff to kids, and kids just have no idea. Not to mention they're probably terrified of you, because there's probably more than just one of you. So there's 3 or 4 people in the living room that I don't know, that's not mom and dad. And by nature, they're just designed to freak out. And that's what they do. They just freak out. In my brain, freaking out is they're crying. Crying means they got an airway. If they can mentally decide that, you know, this is a stranger danger and I'm going to cry and I'm going to hate you, I'm cool with that, because that puts them in a mental appropriateness box. So if they look at me and they're totally cool with coming to me and they're an infant, or more like the 3 to 5 group, if they're totally cool with this stranger just snatching you up and taking you out of the house, then I have more concerns than I would have if they would have just freaked out originally. So I'm looking for that. Let them cry, let them freak out. That's all appropriate for the current situation. And I'm good with that, and try to get as much as you can from mom and dad. Hope that makes sense. As far as the geriatric patients, again, we know that all of these diseases, they're going to be worse because they've had time to sit and develop. We know that some of the trauma is going to be worse because they can't even necessarily tell you specifically what's wrong. They may not have pain receptors that are functioning fully. The book likes to talk about the stove. You know, if I were to touch a stove, or you were to touch a stove, you'd immediately withdraw because it hurts. Geriatric patients, those pain receptors in the fingertips and in the capillary beds, they're not functioning appropriately. The message never makes it to the brain that, hey, stupid, this is hot, get your hand away. So the burns, by the time that process happens, that those neurotransmitters fire off and say, hey dummy, move your hand. They've sustained more of a burn because, again, it just took more time to withdraw from the pain. So assuming everything is normal and we have a fully responsive medical patient, we get a chief complaint, which is the patient's own words. Again, that gives us a level of alertness that starts to elaborate on what their airway status is, what their breathing status is. If there's pill bottles all over the house, we know that there's clues that maybe we need to ask those questions. What is your medical history? Why do you take all the medications? So this is just the patient's own words, the chief complaint. Then we ask them about their history. So, you know, what is the problem today? What is your sample? What is the past medical history as it relates to that? Why did you call 911? This is actually a surprisingly difficult answer for some people. Well, I don't know. Why did you call today? Right. Well, I've got this pain that started last month, and cool. It's 2:00 in the morning. Why did you call today? And you go in a circle, and eventually they say, because I just got tired of the pain, or I'm overwhelmed by it, or I don't know, my doctor told me to, or whatever it is. But the answer to that question is generally your chief complaint. So why did you call 911? Well, because blah, 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 blah hurts. And that is your chief complaint. If they can't give you that, then we think about all this other stuff, but a lot of this other stuff will manifest pretty obviously to you. Hypoxia, they'll tell you, hey, I'm having a hard time breathing, or, you know, glucose, you'll know all this stuff just by doing your assessment when you get a blood sugar and so on. So again, they're still conscious. These are responsive patients. We need to try to start putting together the puzzle. So we start putting together all the pieces. We try to figure out if they've had past problems, if the past problems feel like or seem like the current problems. And again, all we're trying to do is come down to our 2 or 3 differential diagnoses. And that's something we're going to spend a lot of time in as the class goes on, is what are your differential diagnoses? So here's a patient, here's the vitals. What do you think's going on? And hopefully that list is somewhat extensive. We're hoping that, you know, there's maybe 4, 5, 6 things on there that we can start kind of whittling away until we get down into like honing in exactly what we think is wrong with the patient. So we talked about some of this stuff. I'm going to kind of skip through that. We know family history is pretty important when we look for risk factors. You know, is there somebody in your family that died of stroke, or that had some kind of stroke? Is there cancer in your family, heart disease and stuff like that? Social history, again, do you travel on a regular basis? That's pretty important. Have you had any major changes in diet? So somebody that's got an altered level of consciousness, or somebody that's that appears to be frail and just generally unwell. Are they taking in enough nutrients and minerals? We know from earlier on, if they're not, then their body's probably not producing the glycogen or the glucose, which doesn't create the ATP, which means they don't have energy to physically function. So this is where that actually becomes a real problem. If we can identify that kind of stuff, that's a pretty easy treatment. So past medical stuff, this is all covered in the sample history. Are there past surgeries? Past surgeries don't necessarily matter. I don't know. Again, the ear tubes and stuff like that, I don't really care about. But if they have a giant zipper in the front of their chest where somebody went in there and rooted around, that's a big deal. If they're having chest pain today and they have a zipper, that's a huge deal because somebody's already been in there doing work. And if the drywallers forgot some stuff in there, or something went bad, or the stents they placed, or whatever the case is, if a cardiothoracic surgeon went in there and rooted around, they probably need to go back to a facility that has a cardiothoracic surgeon the next time they have chest pain. Because again, we just don't have the ability to fully go into the nuts and bolts of the diagnosis of that cardiac history. So we take them to the appropriate facility that does, and that can only happen if we have a good sound medical history. So lastly, the mental health world is becoming more and more common. The transports and the facilities that can accept the mental health patients are starting to deteriorate. So, Fort Hamilton has recently got rid of their psychiatric area in the ER. Westchester Hospital never really had one. Good Sam has like a geriatric, but they don't necessarily have. Well, they do have an adult. They can't do like pediatric or teenage level psychiatric patients. So there's this whole weird algorithm of where we can take a patient to be considered appropriate. So, and a lot of that is just going to be a learning curve once we get out of here. But as far as school is concerned, mental illness, we have to take them to an appropriate psychological hospital or psychiatric hospital. And that's really what we're looking for there. So any questions on responsive patients? Again, this is a lot of information, but hopefully we're just elaborating on something you already know. We got about 15 minutes, so I'll talk about some unresponsive patients real quick. And a lot of times, like I said, these are the easy ones. These are super, super easy. When you get into cardiology and you look at the monitor and there's a flat line on the monitor and they're in asystole, that's an easy rhythm. There's no interpretation. There's no thought process. It is a very, very simple step-by-step thing. It's decided for you. So unresponsive patients are somewhat the same way. Objectively, you can only go on what you can find and what you see. So you rely 100% on your head-to-toe assessment. So you go through that as your main diagnostic tool and you treat it. And that's really what it is. You treat what you find. For the trauma patients, this is technically, by the National Highway Traffic Safety Division, this is technically life-threatening mechanism of injury. These are examples of that. So the National Registry, they do like to ask questions about like pediatric falls. What is a significant life-threatening mechanism of injury? Well, for a kid, and we'll talk about this again in pediatrics and in trauma, but in general, a fall greater than 10 feet. Sometimes they'll talk about a fall greater than twice the height of the child. But that's, again, this is textbook, and this is probably the better way to kind of remember this. So if a kid falls from, bleachers, off the back of bleachers, and the bleachers are about 12 feet in the air, that is considered a life threat for a child. That's a pretty big deal. So again, these are all mechanism of injuries. The death in the same compartment for a car wreck and major intrusion or ejection, stuff like that, that all kind of goes without saying. That's a pretty significant impact or injury. My man here that fell from however far is unconscious and bleeding from the head. That looks like a legitimate issue. So again, as you're responding, how did he fall? Where did he fall from? Did he fall, or was this a gunshot? These are all things that kind of go through my mind. Just seeing this, right now, just as it pops up, looks like he's either in a street or in a parking lot. That could kind of lend to what's going on. Yeah, so parking the ambulance, blocking traffic, having law enforcement with you, all of that stuff, super, super important. I've also got a theory, and you guys have probably already heard it, but all significant traumas, and I shouldn't say all because I should say most, but most significant traumas involve losing a shoe. Why that correlates to anything, I don't know, but that's a thing. I'm going to publish that someday. If you see a patient that has gotten a car wreck clean out of his shoe, please remember that's bad. If the motorcycle wreck causes a shoe to be removed, that's bad. That's the Adam version. But in all honesty, if they took some kind of impact hard enough to lose a shoe, we're going to go with that's probably a pretty significant mechanism of injury. And now that you're thinking about that, apply that. Seriously, it's almost amazing that how many patients actually lose their shoes as a result of some kind of traumatic event. Just a thought. Or trauma patients. So here's the fall from 2 to 3 times the child's height. That again, 10 feet is a good standard if you need like a hard number. But specifically any loss of consciousness, or they say bicycle crashes, but I'm not super concerned about that. The book is, other than they can have some type of pelvic injuries and some other injuries from not only from the bike and being entangled in the bike, but also from the landing after the fact. So again, things to think about. For registry though, it would be a pretty good idea for us to start thinking about this 2 to 3 times the height, because again, that is a pretty standard question. That seems to come up quite often. So what is considered a dangerous fall, a fall for a child, and that's 10 feet or 2 to 3 times the child's height. Again, that doesn't necessarily mean that it has to be that. It can be less than 10 feet, but they just happen to land on their head or whatever it is. And usually if there's one injury, there's multiple, and I think we're pretty good at knowing that. So I'm gonna kind of skip through. I don't really want to go too deep into something new like body system. So I think we're going to stop here. I think we've probably done enough damage today to kind of get a good idea of kind of where we're at. Take a breath. A lot of stuff, I know. What questions do you guys have? Are there any at all? There's really nothing.
Are we going to take the Chapter 9 quiz? I did the Chapter 5 one during that long break we had, but the other one, you didn't mention anything about Chapter 9.
So originally I wasn't going to do the this midterm or this section exam. So I'm gonna let the section exam count for what it is. That section exam I had mentioned, and I think there was a couple clarifying questions about which questions I'm going to give credit to. The hyperkalemia questions, they are correct in the way they were presented. There's a subtle difference in wording that made an answer a right answer versus a wrong answer, and I don't really like splitting hairs. So I have no problem giving credit to you guys for those hyperkalemia questions. So that is going to count as an exam grade. You guys are good. That's already been posted in your Schoology account. So the long-winded answer for your first question is I'm not worried about the Chapter 9 exam that's in there. If you do take it, if you don't take it, it doesn't count against you. But if you do take it, then it's going to increase your GPA from that homework quizzes section that you get graded on. So again, that's optional at this point. I'm not super concerned about that. Later today, I'm going to post, I'll post some stuff for, probably not for Chapter 6 for documentation. That's done. We've already tested on it. We're moving on. As of today, like I said, we're back on track. So actually, I probably won't post any homework. Yeah, I will. I'll post the Chapter 11 knowledge objectives, the ones I want you guys to do, and you guys can work on them. We don't have class in 3 days because it's a weekend. It'll be Saturday, so I won't see you guys again until next Tuesday. So I'll give you plenty of time to get some of those done. Keep in mind when you're going through the Chapter 11 stuff, I'm going to put all of the ones, there's 20 of them total in the book, and I don't want you to do all 20, but the ones I'm going to put up there it's going to cover information that we're not going to cover until next day. So just by doing it between now and then, it's going to at least get you in the book and get you kind of prepped for what we're going to go over on Tuesday. So otherwise, I'm really, really impressed with the exam scores. I think the average score on that was an 85.9. For me and my brain, for me as an instructor anyway, to be effective, I need that to be somewhere in the 80s as an average. Some of you guys got in the mid and low 90s, and that's phenomenal. But by and large, 100% of us, we hit that 76% mark for passing. So that's awesome. You guys should be happy about that. This is an extremely difficult way to learn, and you guys have been knocking it out of the park. And you knocked it out of the park with the really, really crappy information. So I'm really, really proud. Like that's really, really good. You should be really impressed with yourselves for that. The pH and the A&P and all that garbage, it's really, really tough to digest. And again, because it's not tactile, I can't physically show you like, hey, this is an IV catheter and this is how we use it. You guys have all this philosophical stuff, like, this blood serum level and all this other garbage that's been floating around your brains, and you guys crushed it. So I am really, really thankful for the work you guys have put in already. If you keep on doing what you're doing, we'll be golden for this. I really do have high hopes for this class, and you guys are my first medic class officially through Butler Tech. So I really appreciate that. Any feedback, let me know. Just kind of keep up what you're doing. If you got questions or concerns, let me know. Again, I'm here till 5. So shoot me a text message or something if you want to chat about something. But what's done is done. What's in the past is in the past. So, those that first section in the book, if you actually look at the book, we're like a quarter of the way through the thick book already. And it doesn't feel that way, but we are. So, we're really rocking and rolling. And it seems like everybody seems to be kind of getting the information. And again, I haven't really had anybody say this is flat out awful, or I flat out am so confused, I don't know what to do. So, either it's all going well, or you guys are truly getting in the book. And either way, I can't be more appreciative. So again, let me know. Have yourselves a phenomenal weekend. If you guys have anything, I'll be here again till 5 today. I'll be over in that other virtual area. And as soon as possible, get any questions that you have that needs to go to Bill, get them to me. The ones that were posted in this chat, I already have. So as it related to, it looks like masks, and specifically masks were the big one. I'll get clarifying, on what constitutes a mask and what we need, and if we have our own, can we use our own and stuff like that. So I'll figure that out. I also want to ask about your money. Jeff had mentioned getting that CARES package money. Bill hasn't mentioned that, and I have not heard anything else since. But if that's something you guys are entitled to, I want to get that moving. So I'll add that in there. Trying to think what else. I think that's really about it. So between now and next class, there's not going to be a quiz next class because we haven't completed a chapter that we're able to quiz on. So just get in chapter 11, go through that. Finish the knowledge objectives and submit those in, and that's about it. Questions for me, let me know. Questions for Zach about Google Hangouts or any of that. He's still trying to get all that finalized for you guys, and I think that's really all I got. Anybody got anything else? Rude remarks? Nothing? Hurt feelings? Anybody injured? God, if you get injured during this class, I swear we're gonna have to have chat. Cool. All right. Well, I will see you guys next week. You guys take care. Be safe.